Good evening, ladies and gentlemen. Thanks for watching us today on the Healthy Life shows on KTV 2s. I'm Dr. ANOUD JUWAIHEL. I'm a family physician. I'm so glad actually to be the host for today's. Today's episode is going to be purely about allergies. So if you have any question about this topic, you can contact us through the information provided on the screen right now. Before we start to interview our guests, we're going to view a conference which has been done actually last week, and it's actually the first Kuwaiti North American conference about neurology, and it was under the supervisions of Dr. AHMED We're going to see the conference right now, please.
Kuwait and North America, and this is one of the biggest conferences in Kuwait, where the registration exceeded 600 people, which means the conference is very important to us, and the treatment for the neurology patients, it's advancing, and there is a lot of medicine coming up. There is a surgical intervention for these diseases, especially epilepsy, and we are taking care of that, and we are trying to even build a bigger hospital for the neurology department, inshallah.
Dr. Jassim Yusuf Al-Hashil. I'm the director of the neurology department in Ibn Sina. I'm the chairman of the Conference of Neurology here in Kuwait. So today we opened the first type, or the first of its kind, the conference in neurology, the first Kuwait North American Neurology Conference. There are 13 speakers from USA and Canada. They are really distinguished speakers. They speak in big meetings in the United States and in the conferences. This conference attracted more than 600 people for the conference, and the topics, there are 36 lectures in this conference to be delivered over 3 days, touching in all diagnoses in neurology, and hopefully the meeting will have the success to the end. So far everything is going very well. Well, we don't have a paper representing. We do publish, the department published so far 3 papers has been published, 2 already submitted, and we have 5 posters in the Faculty of Medicine University. In May we'll present 5 posters of those our papers work during the past year.
Professor Richard McLaughlin from London, Canada. I'm a neurologist and an epilepsy specialist, so the organizers of this meeting have me here presenting 4 talks, all on various aspects of epilepsy, which is a common neurological disorder. So 3 of them are this morning, so it's keeping me quite busy. Not MS, epilepsy, seizures. So they have me talking about, one of the main talks is what to do when someone has seizures that can't be controlled with medicines. And when that happens, one of the things we look at is surgical management in some people who have seizures coming from one part of the brain. We can take out that part of the brain and then stop the seizures. It's a very complicated process, but I'll be talking about some of the aspects of how to do that.
Dr. Mike Nicole from London, Ontario, Canada. I'm an associate professor in the Department of Neurology. Well, I'm talking about my main specialty is in neuromuscular diseases, so I'm talking about several things. I'm talking about the approach to patients with peripheral neuropathies, approach to patients with muscle diseases, and then my own particular subspecialty interest is in a disease called myasthenia gravis, so I'm presenting 2 talks on myasthenia gravis. Well, I think we're using a lot of different drugs to suppress the immune system in myasthenia. Some of the new biologicals, there's a compound called rituximab that's a monoclonal antibody against B lymphocytes that's very effective in patients who don't respond to some of the other treatments.
Okay, welcome back. I'm so glad actually today to introduce one of our medical doctors. She is a consultant in internal medicine, allergy and immunology, Dr. AHMED. Thank you. Hi, doctor.
Thank you for the kind invitation, Dr. ANOUD.
Well, I'm so glad actually to have you today and interview you today. Doctor, today we're going to talk basically about your specialty, which is allergy. As we know, like allergy is a small word, but it has a lot of branches and a lot of meaning. I mean, and it can contribute to different parts of the bodies. So can you just define for us what is allergies?
See, the field of allergy is a quite unique field. It's one of the oldest branches of medicine that has been established all over the world. And basically it deals with all allergic reactions, any allergic diseases that affects the human body, you know, starting from the different organs. If we talk about allergy does not have a single organ, it's a system. It has to do with the immune system, it has to do with the pathophysiology of the human body. So anything related to allergic reaction contributing to the respiratory system or the gastrointestinal system or neurological or other organs contribute to the field of allergy. In another word, we all deal with an immunoglobulin that is an IgE. Anything that is related or leads to a secretion of IgE is called allergic. So that comes to us. So we are actually, I think we are very blessed and lucky as allergists that our field overlaps with many medical fields and many other subspecialties. Our field overlaps a lot with the respirology or respiratory medicine, with dermatology, with the ENT, with the gastroenterology, with the hematology and rheumatology. So we have a lot of friends.
So you have a lot of
a network. So we have a very, very collaborative network that we deals with, because we see common diseases, common reactions that we need like a teamwork to deal with that.
That's very nice actually. Like for me as a primary physician, we see a lot of cases with allergy, to be honest, and I see like before, like maybe we see one cases like or a couple of cases like seasonally, but now like maybe every day like we see a lot of allergic cases. So is the incidence of allergies increasing? How common is it?
So the incidence or the prevalence now of allergic diseases is increasing globally, worldwide.
Globally.
So this is in North America, same like the census from the European countries, and we in the Middle East, and especially in Kuwait, we encounter this on a practical basis. So we see it on a daily basis. The incidence now for most of the common allergic diseases is on the rise. These are on the rise.
Yes.
The most common that we encounter are the respiratory allergies as well as the skin allergies. And we can discuss, there are many reasons, many factors related to that, but we see them in practice, as well as all the literature is supporting the wild increase in the incidence all over.
What is the main cause of this rise in the allergic incidence? I mean, is it environmental? Is it related to ozone problem?
Well, now the textbook will tell you genetic and environment.
Yes.
And this is contributing factors related to the pathophysiology of many diseases, right?
Yes.
We in Kuwait or in the Middle East or in the Gulf countries, we have a high increase or high intermarriages. So the genetic is quite strong in emphasizing the allergy gene.
Yes.
So this is, this is
one,
well known.
yeah.
Now we come to the environment that we all are experiencing. The environment is changing. There is a global change in the weather. There is a global change in the environment, and it does affect the allergic disease at a higher rate. There has been many international conferences, and actually we recently have establish a campaign looking into this global warming, global change in the environment and its effect. A sandstorm is one of these, the changes that has happened and its effect on respiratory diseases.
Exactly.
So when we discuss the environment, we talk about the ozone, as you mentioned correctly. We're talking about the increase, the global warming, increase in the rise in the temperature, global warming. We'll talk about pollutants, pollution, air pollution. We're talking about the smoke, the chemicals. So all of this, not to mention the pollens, which are the pure allergens that are causing our main allergies in Kuwait or in the Gulf countries.
Yes.
Many papers right now are talking about the interaction between these pollutants, these chemicals that contribute the change in the environment and the allergen from one side. In another word, we are not manifesting allergies in the same straightforward symptoms.
Yeah.
We are facing now more aggressive season of allergy. We are facing more invasive pollens, as if that the pollens are more aggressive, and they contribute to more difficult symptoms of allergies. And that's why most of the patients, they complain about allergies throughout the year.
Exactly, that's what I'm seeing actually in the primary care.
So it's not anymore a season where we can tell that there is a high rate of pollen count or pollen grains in the environment. No, it's the behavior of these pollens have changed or mutated, if I can put it. So the mutation of this is related to the environmental changes that happens.
Okay. And what is the different type of allergies available? How can we classify allergies?
Okay, so we talk about the most common allergies in Kuwait. We have the respiratory allergies. We all agreed upon that. We have the upper airway allergies, that is the allergic rhinitis.
Yes.
Allergic sinusitis or rhinosinusitis. We have allergic rhinoconjunctivitis, that is affecting the eyes and the conjunctiva. And then we have the lower airway, which is mostly the allergic hyperreactive disease or the spectrum of allergic bronchial asthma. So this is the airway allergies. And this is the commonest worldwide and commonest in the Middle East and commonest in Kuwait, especially after invasion, especially after all of these chemicals and the oil burns and they have contributed to the air pollution. And indeed there has been a rise in some of the allergic respiratory diseases. This is the most common. The second common is the skin allergies. And skin allergies, if you have kids many of the parents, they come with their kids with the atopic dermatitis, with the spectrum of eczema, with some skin itching, the skin rash, the hives. This is all the spectrum of skin allergies, and yes, indeed, this is the second commonest in Kuwait that we see. The third common cause or type of allergies we see is the food allergy. Now, food allergy is a main problem in both adults and pediatric population. However, we see it mostly in pediatric. It's about the true allergy incidence, about 5% true food allergy, and that contribute to the 6 or 7 main categories of food allergies.
Okay.
It is less common in adults,
Yes.
Partly because they outgrow the allergies, and partly because there is other diagnosis than food allergies. So they are talking about the incidence of about 3%.
3%.
So it is less in adults. The third type is a drug allergy. And drug allergy is another problem. I think this is a very unique problem. It's I think it's a branch of allergy or of medicine in general that has been underestimated.
Yes.
It's underestimated. It has been underdiagnosed, unfortunately. We don't have a true incidence, and that's because it's very confusing for the physicians. So we have problems even in referrals of a drug allergy to get the full workup and the full diagnosis.
I think you have a special interest with regard to the drug allergy, so we're going to talk about that also.
Inshallah, that's why I think it is unique, and you will feel very happy once you diagnose or exclude a drug allergy case, and you tell the patient that you are safe, you can take this drug whenever you need it. He will be very grateful to you.
Yeah, we'll be happy, definitely.
Absolutely, yes.
Yeah, and what about the insect type of?
Yes, this is the least. So worldwide there is something called insect or venom allergy.
Yes.
And that's related to the insect bites, to the bee venoms. The bee venom is well known for its high allergic potential. When I say high allergic potential, that it might cause an anaphylaxis or it might lead to death. Yes. So I always instruct our colleagues, beekeepers, not to take it lightly, especially if they have been stung already by bees and they have local reaction. They manifested some sort of swelling or itching at the site of the sting, that they should seek medical advice and then get the proper diagnosis of allergies or exclude it.
Dr. Amina, after passing through this nice classifications of the different type of allergies, we would like to know how does the patient actually present with these different type of allergies with regard to, for example, the respiratories.
So in the clinic we see patients with the respiratory diseases. They come, they have the airway, upper airway as allergic rhinitis. They come with the sneezing, and actually nowadays this is the peak of the allergy season. We are at the end of April. We're passing April till end of May. This is the peak. Most of our patients already are symptomatic. They come to us with the typical classical symptoms of runny nose, itchy nose, runny eyes, tearful, itching and swelling, red conjunctiva, bruised conjunctiva. They can have a blocked nose. They can have some irritation in the throat, difficulty in swallowing, and that can proceed with some tenderness in the sinuses, some headache, they get it, pain, deep-seated pain behind the eyes where the sinuses are inflamed, especially if it correlates with the allergy season. So this is the typical of allergies related to the nose. Now some other patients, they have the spectrum of nose as well as lung allergies. So they come with the other end of coughing, breathing difficulty, chest tightness, especially during the peak of the pollen, especially during dust storm. They come with wheezing, like the sounds in their chest, difficulty in sleeping. And I think, if you ask these patients, the most sensitive symptoms or signs that they could tell you is that there is a difficulty in going to sleep, waking up in the early morning with symptoms in the chest, and this is the most sensitive
That's a
sign.
good question to ask for the
This is basically, and cough of course. These are the spectrum of the respiratory. It doesn't have to be all.
Yes.
You know, usually you don't get a very ideal patient. He can just get one symptom or another that is predominate in one patient.
Yeah.
So you don't get the full spectrum of all of these symptoms. It can be only cough. So in this case, we call it a cough variant allergic asthma, or it could be the breathing difficulty or the wheezy, especially in kids, wheezy chest. So this is the spectrum that we are seeing mostly nowadays in the clinic, corresponding to the allergy season.
And is it important for these patients, like especially the patient who present with allergies in the lower respiratory, so for example they have asthma, so if their first presentation is just allergic rhinitis or a runny nose, do they have to treat it as soon as possible?
There's an excellent question, Dr. ANOUD. Basically, we all know that there is a concept. It's a well-established concept called the one airway disease. The one airway disease, it means that whatever inflammation is present in the nose at the time of allergic rhinitis, there is a similar inflammation going on in the lungs.
Wow.
So you have to diagnose it at the time of diagnosing allergic rhinitis. So actually most of the doctors, they are smart enough and they know already that when they are dealing with allergic rhinitis, they have to investigate at the same time, looking for some inflammation or something going on in the lungs to diagnose it, and if needed, to treat it. Some patients, they might not have the chest symptoms. They will tell you, like, you know, it's mostly the nasal symptoms. But if you ask them very precise question, they will tell you, yes, we do have sometimes during some nights that we have some breathing difficulty or chest tightness, especially with the weather, when we have a big load of dust or humidity, then it triggers their inflammation in the lungs. So we need to diagnose these cases, because all the evidence now supports that treating the lungs at the same time where you are treating the nose actually prevent the progression into a full-blown asthma.
All right.
So you are doing a preventative measures by diagnosing the inflammation. And when I say inflammation, I mean the hyper-responsiveness or hyper-reactive airways. That it's usually the early signs or the early manifestation of inflammation that's going on in the lungs.
Yes.
And then once you diagnose it, you can start the preventative treatment with a different, treatment modality we have, and then
You will save the patient.
Of course, you will save him actually a complication of turning. This is very clear. We see it in kids.
Exactly.
School children. Because the progression of what is called atopic march is that they start with different patterns or different presentation of allergies. They have the allergy gene, but it keep differentiating from eczema into allergic rhinitis. Then by toddler or by the school age, they will develop into bronchial asthma.
Okay. This is very nice clarifications, actually. So if we want to go through the food allergies that you say, can you just define for us what is actually food allergy, and how can we tell the difference between food allergies and food intolerance?
Okay, you don't want to have a food allergy, first of all. If you have to choose between food allergy or food intolerance, you better choose intolerance. Now, food allergy is a real medical problem. It's a real medical, we'll say, it's a dangerous diagnosis. This is a true allergic reaction. It relates to the histamine, it relates to the IgE that I was talking about. It relates to the danger of ingesting any food that you are allergic to. This might, leads into allergic reaction or an anaphylaxis. As I said, the incidence is on the rise. This is we have the prevalence from the North American. The main, we see it both in pediatrics and in adults. The main families or the main food allergens or food proteins that are responsible for food allergy are well known, and most of the patients usually, especially the parents, they come to us asking us to clarify this and that in terms of the allergies. For pediatrics, we have wheat, we have eggs, we have cow's milk, we have nuts, mixed nuts, we have peanuts,
Yes.
and we have soya. And fish or shellfish, these are least.
Yes.
When we come to the adults, the most common in adults are the fish, the shellfish, the mixed nuts, the peanuts. These are the commonest in terms of inducing allergic reaction.
Yeah.
Some of the food allergy are quite dangerous in terms that the child will not outgrow it. For example, we know that shellfish allergy is a very long-standing, so we have to keep testing the patient. He have to avoid the food.
Yes.
This is no-brainer. He has to avoid. Once it is diagnosed that he has a food allergy from, for example, let's say shrimp,
Yeah.
he has to avoid shrimp lifelong.
Yeah.
This is number one. Number two, he have to regularly check with his allergist to do regular testing, and so that if the test, the allergic test comes back as low, the allergist will introduce the shrimp in the office or in the clinic and see if there's a reaction. So it is much safer for the patient.
Yeah.
This is what we're talking. For example, peanuts. Peanuts is one of the nasty proteins that cause allergies, and it is number one sensitizer in North America. Most of the kids, it's number one actually allergen in terms of inducing food allergy.
Yeah.
Peanuts as well as cow's milk allergy. Now when we talk about peanuts, we know now from the literature less than 20% around that they outgrow of it, so it is quite dangerous.
We will go through that talking about the food allergies, but now we have actually a commercial break, and then we're going to view a conference which was also held last week about rheumatology disorders in GPs, and we would like to have a break right now. Thank you.
Farid Al-Kandri. I'm working for one hospital, consultant of internal medicine and rheumatology. My lecture today will be about gout, and this is really a very important subject. We saw a lot of patients come to the clinic about the gout, complaining of joint pain, and it's important to how to diagnose this problem, the gout, and how to differentiate between the patient with A symptom, high uric acid, high salt in the blood, and the patient with real gout symptomatic hyperuric acid in the blood. So it's important how to differentiate and when to start the medication with this patient. Side effect of this medication is important for the patient as well. So this lecture is for a doctor from the family doctor and general practitioner doctor from the polyclinic. From all grades, and it's so for the doctors, not for the public. So there was a research that the patient about the medication, the patient. We have the usual drug, that Xyluric. We have another drugs coming when the patient couldn't tolerate this kind of medication, and they have side effect. Now there's a drug that approved, and federal drug of USA, and it's a new drug that I'm going to present.
Dr. Khulud Saleh Isa, consultant rheumatology and internal medicine in Farwania Hospital. Today there is an event, actually we are doing awareness for the GPs in Kuwait. So it's citywide awareness for all the GPs in Kuwait regarding the inflammatory back pain, and that is including ankylosing spondylitis and the other types of inflammatory back pain. The main goal of this lecture or awareness is to enhance the referral of these patients to us in order to make an early intervention and treating these patients, because most of these patients are suffering a lot from their back problems.
Welcome back, viewers. We're going to continue our talk with Dr. Minal Ahmed about the peanuts allergies. As you said, this is very lethal situations and conditions. What is your advices for the family with regard, if they have a child, with peanuts allergies? Do you have any special advices for them?
Now, once they suspect a case of peanut allergy or food allergy, they should get this straightened up or diagnosed formally by their doctor. And there are certain allergic investigations that we do to diagnose it. Once we reach the diagnosis of peanut allergy, the child and the parents will be given something called an EpiPen, and that's an adrenaline injectable in a pen device, and that's to be taken during emergencies. We're not telling the patient to go and eat peanut and have this inject yourself. No, he has to avoid peanuts. Now the key thing in that is, and actually it's very demanding for the mother, is really to avoid peanuts completely. Peanuts now nowadays in all sort of food, in all processed food, in all baked food, they have to be quite smart in really looking for the hidden ingredients in all the food meals.
Even in the biscuits or the cakes.
In everything, in sweets, in their regular meals, unless they have it home cooked. In that case, they can control what is in. So let's say the EpiPen is usually given for incidental exposure. Let's say that the child has been invited to a party or a birthday party or going to a buffet where there is a hidden ingredients of a peanut, or he got exposed wrongly to the peanut and then he got a reaction. Nobody can predict the spectrum or the severity of his reaction, but if that occurs at any point, he should inject himself. And usually we train the mother or the parent or the caregiver as how to give the injection of the EpiPen the child himself, if he's old enough to understand how to get the injection himself, we usually encourage him. We usually keep one at school, and we usually keep one at home with the patient wherever he goes.
And what are the symptoms that the child can develop? And
So when he will use it mainly when he have this specific feeling of throat constriction. This is the very sensitive sign that the patient or the caregiver, when he see his child in this symptomatology, he will immediately inject him. The child will start, he might have a skin rash, he might be covered with urticaria rash or angioedema, he will have his whole face swollen, he will have breathing difficulty and wheezing, and he will be gasping for air. Of course, we will not wait and
So
look for all of this. The sooner the better, absolutely. So all the papers now and all the evidence says that actually we are losing patients if we're going to delay in administer EpiPen. If we have the EpiPen and we are waiting for that patient to develop the throat constriction or to come to the later stage, the EpiPen might not work if you give it later.
So even if a pure redness in the skin just appears,
well, we'll say something in the middle. So the patient is reacting, he's developing some breathing difficulty. It has to be at least 2 organ involvement. So we're talking about the skin, we're talking about respiratory or circulating system, the circulation. So they will not check that the patients have a hypotension or a drop in his circulation, but the child is developing some sort of wheezing or breathing difficulty and he's full covered with the urticaria rash or angioedema. We suggest that the mother will inject the child and immediately this child should be taken to the emergency department to be kept on a cardiac monitor, under the cardiac monitor, and then to be assessed correctly.
This is very important topics because the beans is actually as you said, could be even the small contaminations or handling of any nuts or peanuts can actually affect the patient. So any mothers who have a child with a peanuts allergy should have a very well educations of what could harm her children and what things she can do to avoid all this.
It is a big burden on the parents. It's a big burden because a child, especially the younger the children are, it's difficult really to monitor what they are eating or where they are going. It gives a big burden on the mother to look after his diet, and then even to be quite knowledgeable in all the different names and the labels of peanut. The industry are getting very smart now in changing the peanut into other formats. So she has to be aware of that.
Exactly. So what is the investigation available for allergies? If a patient has some sort of allergies, what investigations you can offer them?
So one of the most common investigational tool that we use and quite sensitive is what we call the skin prick test.
Yes.
And this is what we are using. It's a device where we put a drop of a standardized reagents. When I say standardized reagent, it's the proteins of the allergens causing the allergy. We put a drop on the forearm or on the back of the child, and then we prick it with a small lancet or a small device, pointed device, and we monitor that for about 15 minutes.
I think you have a report. We have a report on the skin prick test, so we can see it and then we will see that together. Thank you.
allergenic reagents. Here is a drop spaced on the forearm. So this patient is allergic to, this patient came to me actually with a respiratory allergies, and I'm trying to investigate her and see what is the reason for that. After that, I'm gonna use the lancet or a certain device to prick the skin and wait for about 15 minutes, waiting for a reaction. The reaction that we are looking for is induration, and here you can see that the patient is already reacting. You can see that there is a swelling and erythema. Now what I'm holding here is cow's milk, and this is a fresh milk. So I'm gonna put a drop on that, and also in the same thing do the prick. This is the device I was talking about. It's called the lancet, and we just prick the skin without causing any bleeding. It's not a painful procedure. It's very safe. We do it both in kids as well as in adults. There is no major contraindication for doing this. Here, after the patient has been waiting for about 15 minutes, now it's a time to read the test. And the patient, as you can see, has a very good control. We have to apply a control so that to monitor how we read the test. The patient is negative. This is another patient who actually turned out to be a very allergic patient, and the same thing you can see at the top that he is already reacting with a big size wheal, a big blip, reddish on the top. This gentleman was already allergic to the common environmental allergies. He also had allergic rhinitis. We waited for 15 minutes and we read the test as well.
This is very actually interesting test that you do.
You know, this is the most sensitive test to diagnose, and it is very informative for both the doctor as well as the patient. It gives you a result in 15 minutes. And the type of allergy that we can diagnose with this, we can diagnose respiratory, allergic rhinitis, allergic asthma, allergic sinusitis. We also can diagnose food allergy, and that is the case where we applied the cow's milk. We can diagnose venom. The bee venom, so we have extract for, and we can diagnose also drug allergy. Now, this is, as I said, this patient turned out to be very allergic, and you can see the big-sized wheal that he developed. It's red, it's indurated, and usually we measure it. So what I'm doing already, I'm measuring the wheal at this patient, and this is already a positive reaction. And so this patient is allergic.
How long does the redness will stay like this on the skin?
Well, it's a few minutes. It will go away within like 15 minutes. I usually will put something just to take it away. I already marked, you know, the induration just for the camera to see clearly the big size of his positive reaction.
This is very nice test, and it's very informative because it's going to tell us exactly what is the allergen, and it's actually going to lead us for the treatment.
And it is, you know, it's very good also for the patient to see that he is, you know, he will understand his problem. He will get results from the first visit that he's seeing his doctor. So the first time he's coming with a complaint, he will come out with answers, so he knows what he is allergic to.
Yeah, I think, Doctor, we're going to move now to drug allergies, and I think you have a special interest in that.
Yes.
Can you just go briefly on the different types of drug allergies we have? And
so, as I said, now drug allergy is the least, you know, understood among the types of allergies in general. It's underestimated, it's underdiagnosed. Worldwide, we have the commonest type of drug allergies are the antibiotics.
Exactly.
And among the antibiotics, we have the beta-lactam or the penicillin.
Exactly.
We call the penicillin family. This is the commonest. And you know, penicillin is among the eldest or the oldest antibiotic that we have available.
Yes.
We've been treating our kids and our patients with that for a long time. So because we are encountering this antibiotic for a long time, the allergy, you know, has been on the rise. So this is the commonest. Second common drug allergy is the painkillers. The aspirin. Aspirin family, aspirin, brufen, the cataflam, all of this family.
Yes.
This is the second most common allergies related to the drug field. And then we have the anesthetics. Anesthesia sort of agents, the general anesthetic agents and the local anesthetic agents. These are also among the common worldwide. Now, unfortunately, here in Kuwait, we don't have a local data as what is really common in terms of like incidence or a prevalence of a drug allergy. As I said, partly because we don't get many referrals. Many doctors, they feel like it's enough to just label the patient's
Allergic to
penicillin allergy and just have this red banner on the file, on the hospital file, and that's it. This is not enough. The patient will be actually avoiding penicillin, or the other doctors will be avoiding using penicillin for a long time, and preventing this patient from a formal diagnosis. And we know for sure that if he got tested, up to 90% he will tolerate, it's negative, or he will tolerate penicillin.
Yeah, because sometimes they just appear diarrhea, they just call them it's allergic.
It's allergic, or it's so it the symptoms are very unique for the drug allergy. It's similar to the IgE mediated reaction. It has to be very close in terms of duration when taking the antibiotic or the painkiller. But the formal diagnosis is a must for a drug allergy, because you're going to save the patient. What is happening now, you're aware as a primary care physician, you're aware that about the campaigns of restricting the use of antibiotics or the proper use of antibiotics. What is happening here, that we are avoiding the use of the common or the least invasive antibiotic because there is a fear of a drug allergy, which I don't think it's a true drug allergy. These patients have not been tested. So what we are relying on as a doctors, on a higher invasive or higher class antibiotics, like meropenem or other like classes. So the problem of drug resistance or antibiotic resistance is going to come up, and the patient will suffer.
Okay. Doctor, we just have a question coming up from a person called Abu Abdullah, and he said that he has a kid less than 1 year, and he said, is it okay for his kid to have a skin prick test?
Yes, no problem.
There's no problem.
No
This is
problem.
quite safe.
Yes.
Okay. So we're just going to continue now on the management of allergies. Like we will have just a broad talk about it and a brief talk. So as we all know, like in primary care, we always have a preventive measure and we have medications. So what is the preventive measures that we have for?
So for allergies, if we talk about respiratory allergies, if you're going to tell your patient avoid coming up or coming out when the pollens, this is really a joke. Nobody can escape the weather or or immigrate or it's not practical. Let's put it this way. It's not practical.
Actually,
So we all live here. We have to customize. So I always tell my patients, you don't have to change the environment. You have to change yourself. Right? You cannot take away all the weeds and all the grasses and all the trees to make it like a pollen-free environment, but change yourself. So this comes to the cure of allergies. When we talk about cure of allergies, we're talking about really stopping this atopic march or curing the allergic rhinitis in these patients. And the cure I'm talking about is the allergy vaccine. Many of the patients are aware of something called allergy vaccine. It's a vaccination against whatever they are allergic to. So they have to be tested, they have to be diagnosed with certain allergies, and then they have to be offered according to what vaccine tolerates that. The course, there is injection and there are drops. The course is about 3 months to 5 months for the drops, and about 1 year to 3 years for the injection. Many patients ask me why it is yearly or why it is taking too long, and I said because you live in an environment where you are exposed to the allergies most of the time.
Exactly.
So you have to customize your immune system to the new environment by becoming less sensitive to this environment.
And how safe is these vaccinations?
It's quite safe, you know. Well, I won't say, I will take it back. There's nothing called like 100% safe, but in general, luckily, we have now over 1,000 case has been treated with the vaccine, with the injection one, and over like 400 to 500 case with the drops, and we haven't got a serious or systemic side effects. That is what is reported as, you know, at the site of injection, they might get swelling, they might get some redness, pain, tenderness. This is you know, common sense. In a very few patients, they might have systemic wheezing or you know, respiratory symptoms. Their blood pressure might drop, but these are very few, and it's not as high.
With regard to an asthmatic patient, like I encounter actually a lot of patients, or asthmatic patients in my own clinic, and as you know, we will have to put them on prophylactic medications, and most of them have very poor compliance to this medication, and they actually underestimate the reality or the severity of asthma, and so they just keep on getting back these asthma attack more frequent. Is there a new era, new medication, or new cure for all these patients, you know?
Yes. Now, there is a new medicine that came up recently, and we've been using it for the last 3 years. This medicine is about 10 years old now. It's a new immune-mediated medicine. It relates to the immune system, and it works by decreasing the allergies. It's an injection, it's given by injection around once a month, and it's given to specific types of bronchial asthma, especially the severe ones, the allergic ones. You know, they have to have certain criteria, but this medicine has been proven highly effective in these patients. It reduced their symptoms, it reduced even the rate of the use of medication or the use of steroids. We have very good data locally. The only thing that it is, this medicine is only effective for patients who have severe asthma, and I keep saying it has to be a severe asthma, as has to be an allergic asthma. So they have to classify their asthma into whether it is allergic or non-allergic.
Okay, I've got actually a good question from a person called Khalid. She said while eating eggs, actually, her body will actually go reddish, and she said, is there any treatment for egg allergies?
Okay, so if what she's describing are called urticarial hives, and if it happens within 30 minutes to 1 hour from eating an egg, this is called food allergy secondary to egg. So what we have first to classify if she's allergic to the egg white or the egg yolk. So we have to diagnose that, and if this is confirmed by doing the allergic testing to eggs, then she has to avoid eggs. Period.
Avoid that totally.
Now,
she can't use immunotherapy for that.
No, well, this is a very good question, because nowadays it's not FDA approved yet, but there is an immunotherapy to egg allergy, to cow's milk, and to peanuts. These are the 3 food allergens or food proteins that they have succeeded in developing an immunotherapy to that. But this is very, it's very called state of the art, very fresh news, and we're hoping, inshallah, in the coming 5 years that we're going to have an immunotherapy to some food allergy patients.
She have to wait at least for 5 years.
So she will have to food, and then come and see me.
All right. There's another question from the audience. They suggest that they have frequent sinusitis, and they were asking, what about the sinus patch or the nose patch for relieving the sinus symptoms? What do you say about that?
I think this is one of the local remedies, similar to what other remedies that have been used, or over-the-counter management that they use, or self-implicated. It goes by decrease the congestion, nasal congestion. I don't think that using this topical patches will really relieve or cure their sinusitis or cure the inflammation that they have. They have to get the proper treatment for that if they have real infection or a real sinus episode. So they have to get really, once it's diagnosed and they know they are sinusitis, they have to get the real treatment. It includes the nasal spray as well, plus minus the antibiotic.
Dr. Mina, with regard to the immunotherapy as a treatment, as a cure for allergic rhinitis or sinusitis, would the anatomical changes return back to normal after the cure? I mean, could the inflammation or the inflamed turbinate go back to normal?
Yes. Well, if we're talking about allergic rhinitis plus allergic sinusitis, there is something called immunomodification. So the way that this immune therapy works is by changing the allergic inflammation and make it less and less in these patients. So their sinus will become less allergic, their allergic rhinitis will become less allergic, so they will have less allergy symptoms. And the inflammation, of course, if there is no symptoms, that means there is no inflammation. So inflammation always gonna subside.
This is very interesting talk, actually. There is one extra question, that person with egg allergies, how would they receive certain vaccinations?
Okay, so this is a common question, especially in kids. If they have egg allergy, they have to get their egg allergy diagnosed. If they are truly positive or truly egg allergy, they have to have their vaccine tested. And the vaccine in question are the influenza vaccine and the MMR. The measles, mumps, and rubella, because they have some constituents of the egg protein. So they have to test it. If it is positive, then there is what is called a graded challenge in terms of giving them in a very small titration that we administer under observation, and then the patient can have it. If it is negative, the patient can go ahead and have the full-blown dose without any problem.
Dr. Amina, I'm so glad actually to have you today, and I'm so sorry that we're going to end the show for today. Maybe we're going to meet you for sure in another episode, hopefully. Do you have any certain advices or any last talk or last
So
words?
God bless everybody and keep away, keep away from the diseases. I'm really grateful for the kind invitation, and my last message to the patient is that if they suffer from allergies, there is a cure. I don't like patients to tell me that they don't know what they are allergic to, and they don't know how to treat it, because science is advancing. And nowadays we have, alhamdulillah, we have a cure for many allergic diseases, or an answer at least to many questions.
So they should have the road to you, exactly,
if they want to.
We're so thankful for you, and we're gonna hopefully see you in the next episode. And thanks for everyone watching us today. Thank you.